Researchers developed dry powder inhalers, or DPIs, in a search for an easier-to-use, more environmentally friendly alternative to metered-dose inhalers, or MDIs. Studies had consistently shown that the majority of patients had poor technique with MDIs. Poor technique decreases the amount of drug delivered to the lung and is correlated to poor asthma control. There was also a concern that the chlorofluorocarbons, or CFCs, in MDIs contributed to the depletion of the protective ozone layer. As we will see, DPIs avoid some of the common technique problems with MDIs. But unfortunately, inadequate technique with DPIs is still very common. Instructing patients on proper DPI technique is essential in maximizing the drug effectiveness. Therefore, healthcare professionals should be able to demonstrate correct technique to patients. Although various DPIs are similar, there are some important differences between specific devices. Due to these differences, healthcare professionals should be very familiar with the features of commonly prescribed devices in their practice. The purpose of this video is to discuss 4 dry powdered inhalers, or DPIs, that are used to deliver inhaled corticosteroids, or ICS, individually or in combination with another drug. These include diskus, twisthaler, flexhaler, and ellipta. We will discuss the general mechanism of DPIs, summarize the advantages of DPIs compared to MDIs, demonstrate the proper technique and outline the cleaning and storage of each device, identify common technique errors that limit the effectiveness of these devices, compare similarities and relative advantages for each device, pointing out important factors in selecting a device. In its most basic form, a DPI is comprised of 3 parts: the air inlet port, powder holding chamber, and outlet port or mouthpiece. The outlet port is the mouthpiece which delivers the dose to the patient. The second part is an air inlet port. Outside air enters the device through the inlet port during inspiration. It will be important to point out the inlet port to patients so they do not block it with their fingers during inspiration. The patient needs to inhale at a sufficient respiratory rate to disperse the particles into respirable size particles of 3 to 5 microns. Because it is the patient's inhalation that disperses the drug particles and not the device, DPIs are sometimes called passive devices. The inspiratory rate necessary to disperse the particles is at least 30 to 60 liters per minute, which is significantly greater than metered-dose inhalers. Some patients may not be able to inhale rapidly enough to use DPIs effectively. The third part of a DPI is the drug compartment. In addition to the drug, the powder formulation generally contains an excipient like glucose or lactose as a carrier substance. Glucose or lactose also helps to disperse the drug powder during inspiration into 3 to 5 micron size particles. This is the ideal size particle to reach and deposit in the lungs. Some patients may note a slightly sweet taste from the glucose or lactose. Although the amount of lactose is relatively small, patients who are very sensitive to lactose may not tolerate lactose-containing powders. There are 2 different types of drug compartments in the multi-dose DPIs available in the United States. Reservoir devices contain enough bulk powder for 60 to 200 individual doses. The device has a metering mechanism to correctly measure each dose just prior to inhalation. The flexhaler and twisthaler are examples of reservoir devices. The second type of DPI is a unit dose device. In this type, each dose is pre-measured and separately packaged in a foil blister. The blisters are on a tape which scrolls through the device. The diskus and ellipta are examples of unit dose devices. If the unit dose device contains a combination of drugs, each drug might be in a separate blister. One potential advantage of unit dose DPIs, the additional protection of the drug from moisture. Moisture causes the drug powder to clump, decreasing the percentage of drug particles in the desired range. Drug particles larger than 5 microns are more likely to impact on the throat or larger airways and not reach the lungs. The unit dose blisters may also provide a greater consistency in the measured dose relative to reservoir devices. However, unit dose devices are typically more expensive. Because they contain fewer doses, they are replaced more frequently. The multi-component design and the need for dedicated factory production lines may also add expense. We will talk later about the significance of the type of drug compartment on device storage and secondary expiration dates of reservoir versus unit dose devices. There are several advantages of DPIs compared to MDIs. First advantage is that DPIs are considered passive breath-activated devices. As a result, DPIs require little coordination between the release the dose and inhaling it. This so-called hand-to-lung coordination required of metered dose inhalers is challenging for many patients. The patient's, not a propellant, generates the necessary force to inhale the drug particles. Because DPIs lack a propellant, there are less environmental concerns. Also, DPIs will not have a propellant aftertaste that some patients complain of. Holding chambers are not needed with DPI devices. All DPIs include a dose counter as an alert for timely refills. Because patients receive a new device with each refill, DPIs require less maintenance and cleaning. Many DPIs contain longer-acting drugs that can be taken once or twice daily.